Hello, you're welcome to my platform. I am Dr. Sandra and I am a surgeon. I hope you become aware and sensitized about the different surgical conditions. Today's video is about tracheoesophageal fistulas and esophageal atresias. Tracheoesophageal fistulas and esophageal atresias are abnormalities of the gastrointestinal tract. The gastrointestinal tract is the system of our body where food passes through in order to undergo breakdown into the different forms that our body can use for energy, tissue repair, and growth. The tracheoesophageal fistulas and esophageal atresias are usually present at birth, and they occur concurrently. They occur together. However, the tracheoesophageal fistulas can also occur as a result of cancer or infection or trauma. In a setting where the tracheoesophageal fistulas and the esophageal atresias were present at birth, it is usually as a result of abnormalities in the development of the gastrointestinal tract. Normally, around the 3rd to the 4th week of gestation, when the unborn child is still in the uterus, there is formation of a structure called a primitive gut tube. The primitive gut tube is made of 3 parts. It has the foregut, the midgut, and the hindgut. At around the 4th to the 6th week of gestation, when the unborn child is still in the uterus, there is formation of the esophagus and another structure called the laryngotracheal tube within the foregut. After some time, these two structures are supposed to be separated by a wall called the tracheoesophageal septum. And this makes the esophagus to lie behind this wall, the tracheoesophageal septum, and the laryngotracheal tube to lie in front. After formation of this wall, the laryngotracheal tube grows into the larynx and the trachea. And then the esophagus has to elongate downwards to join the stomach. If this wall does not form to separate the laryngotracheal tube and the esophagus, we end up with a condition called the tracheoesophageal fistula. And if the esophagus does not elongate downwards to join the stomach, we end up with esophageal atresias. In a setting of esophageal atresias, the upper end of the esophagus ends as a blind pouch, and the lower end of the esophagus is usually above the diaphragm, and there is no connection between the upper and the lower ends of the esophagus. In a setting of the tracheoesophageal fistula, there are 5 possibilities that can occur. We have what we call the type A tracheoesophageal fistula, also known as the isolated esophageal atresia. In this case, the 2 ends of the esophagus don't meet. In type B, the upper end of the esophagus is connected to the trachea. In type C, the lower end of the esophagus is connected to the trachea. In type D, both ends of the esophagus are connected to the trachea. In type E, which is also known as the H type, there is usually a connection between the trachea and the esophagus, but the middle part is present. So there is no gap between the lower part of the esophagus and the upper part because the middle part is present. In this case, we just have a connection between the esophagus and the trachea. The risk factors for the tracheoesophageal fistulas and esophageal atresias include if the mother was using alcohol or she was smoking during pregnancy, if the mother was exposed to some drugs, for example, methimazole and diethyl stilbestrol, children that have chromosome abnormalities, for example, trisomy 13, that is the Patau syndrome, trisomy 18, that is the Edwards syndrome, and trisomy 21, the Down syndrome. The tracheoesophageal fistulas and esophageal atresias can also be found in children that have other abnormalities. For example, they have spinal abnormalities, they have anal abnormalities, cardiac abnormalities, kidney abnormalities, and lower limb abnormalities. In a setting where the child only has esophageal atresia, they will present with coughing, choking, and cyanosis, that is, their body will turn blue, especially when they feed. when the mother tries to breastfeed or when they are given a bottle of feeds. It can also be seen when the unborn child is still in the uterus, for example, on ultrasound scan. And the signs can include excessive amniotic fluid in the uterus and also inability to see the stomach of the child on ultrasound scan. Inability to pass the nasogastric tube by the health workers can also be a possibility that the child has esophageal atresia. This can be confirmed by taking an X-ray of the child, and the nasogastric tube can be seen not to reach the stomach. By the way, the signs and symptoms for esophageal atresia of coughing, choking, and also turning blue on feeding usually present immediately after birth, especially after the child has been given their first feed. In children that just have tracheoesophageal fistulas without esophageal atresias, the symptoms will present later on. For example, they will have history of recurrent infection in the lungs, that is pneumonia, as a result of the feeds entering the lungs, as well as coughing and choking after feeds. For children that have both the tracheoesophageal fistulas and esophageal atresias, they also present with coughing, choking, and turning blue, that is cyanosis. And this usually comes after feeds, for example, breastfeeding or bottle feeding. They also have excessive frothing or drooling of saliva from the mouth. They also present with vomiting and abdominal distension, that is, their abdomen will look rounded and bigger than normal. There is something I want to emphasize about the tracheoesophageal fistulas and esophageal atresias. These children, from the clinical presentations that I've just laid out for you, they are prone to getting recurrent lung infections, and they also have nutritional issues because they cannot feed well. So it is very important that you bring these children to the hospitals for surgical management, because there is no other way the children are going to get better without surgical interventions. The investigations that we carry out in children that have tracheoesophageal fistulas and esophageal atresias include karyotyping. The other that we do is bronchoscopy, endoscopy, and a chest and abdominal X-ray. When it comes to the management, in a setting of esophageal atresias, if the ends of the esophagus, that is the upper and the lower end, are close to one another, we just do primary anastomosis. We just tie them together. In a setting where we have a long gap esophageal atresia, that is if the two ends of the esophagus, that is the upper and the lower, are too far apart, we do some techniques that can help us to grow the esophagus, such that after some time we can also do anastomosis. The two ends, that is the lower and the upper, can be sutured together. The techniques that we employ in esophageal lengthening include the focus process, the minimally invasive focus process, the static internal traction, the dynamic internal traction. These are all procedures that we carry out before surgery just to help us lengthen the esophagus, because majority of the time, especially in the long gap type of the esophageal atresias, the ends are far apart and they cannot easily be sutured together because they are so far apart. In patients that cannot benefit from the lengthening procedures, we do what we call the jejunal interposition, where we take part of the intestine, especially the middle part of the small intestine called the jejunum, and we can use it to cover, to bridge the gap between the upper part of the esophagus and the lower part of the esophagus. In a setting of the tracheoesophageal fistulas, we do what we call closure of the fistula, where we resect or cut that connection between the esophagus and the trachea, such that they are not connected together anymore. In addition to closure of the fistula, we can also employ stenting, especially if the fistula was in the upper part of the esophagus and the trachea, and if there were also some complications, for example, narrowing of the trachea. When it comes to the prevention of the tracheoesophageal fistulas and esophageal atresias, please avoid the risk factors. For example, avoid the drugs that I've just told you, that is methimazole and diethylstilbestrol. Please avoid smoking and alcohol, especially when you're pregnant, and also avoid trauma to your bodies, because sometimes you can get the tracheoesophageal fistulas after trauma to your body. Please exercise the precautions that are necessary to avoid trauma to your bodies, because this can also predispose you to the tracheoesophageal fistulas. Yes, that is what I had for you. Thank you so much for listening to me. Please share my videos and also subscribe. See you in my next video. Bye.